Yeah, thank you very much for the opportunity to participate in this very interesting symposium. So my name is Stefan Frohling. I'm at the National Center for Tumor Diseases and the German Cancer Research Center in Heidelberg. And I'm a physician by training, and I work at the interface of clinical oncology and applied cancer research. And in my talk, I would like to discuss the clinical value of comprehensive molecular profiling in the care of patients with malignancies, particularly solid tumors. And I've chosen to illustrate the clinical value of broad molecular analyses using a particular group of tumors. And these tumors are the soft tissue sarcomas. Soft tissue sarcomas are a remarkably heterogeneous group of rare malignancies that can occur in virtually any body region and that are derived from the tissues indicated on this slide. And progress in the drug treatment of soft tissue sarcoma is slow and has been hampered by a lack of adequately sized clinical trials, which also often fail to account for the heterogeneity of soft tissue sarcomas. And there are only few clinically validated molecular drug targets when you compare these diseases with other cancers. Despite this overall unsatisfactory situation, I would like to recall as a ray of hope, so to speak, that although soft tissue sarcomas are often challenging to treat and we have comparatively few drug therapy options available, they also represent a group of diseases in which several precision oncology milestones or personalized oncology milestones have been achieved. This is, of course, the case for the targeted blockade of the mutant KIT receptor in patients with gastrointestinal stromal tumors, as shown on this slide, but also for more complex alterations that are exemplified here by the discovery of pharmacologically targetable rearrangements of the ALK receptor tyrosine kinase in patients with a rare disease called inflammatory myofibroblastic tumor. And this slide summarizes one of the first case studies published in 2010 that reported on the therapeutic efficacy of crizotinib, a combined ALK and MET inhibitor in this disease, whose value as therapeutic targets could also be demonstrated in a multi-center phase 2 study conducted by the EORTC, the European Organization for Research and Treatment of Cancer, which found a disease control rate of 100% among patients with ALK rearranged inflammatory myofibroblastic tumor. And another particularly striking, fairly recent example are rearrangements of the NTRK receptors, which, as in many other entities, are associated with remarkable sensitivity to NTRK inhibitors such as larotrectinib, as shown in this diagram, or entrectinib in patients with different soft tissue sarcomas. So based on these and many other examples, there is no doubt in my mind that molecular genetic analyses are already of considerable importance for the treatment of patients with soft tissue sarcomas. However, the question arises to what extent such analyses, which can range from looking at single mutational hotspots to sequencing entire genomes, should be performed. And this diagram illustrates how we have organized molecular stratification or molecular diagnostics at my institution at the National Center for Tumor Diseases in Heidelberg. On the one hand, and that's the green box, there is routine molecular diagnostics, which primarily involves gene panel sequencing and targeted gene expression profiling. On the other hand, and that's the blue box, we run several specialized programs that systematically use whole genome and RNA sequencing in specific patient populations to guide clinical action and develop new concepts for molecularly informed clinical trials. And one program that is of particular importance to my own work, I would like to describe in more detail. And this is the MASTER program, which focuses on young adults with advanced cancers across entities and on patients with advanced rare cancers across age groups. And within this program's framework, the collaboration of 11 comprehensive cancer centers in Germany with their respective catchment areas has resulted in a close-knit precision oncology network that now comprises more than 100 partners across our country and represents the entire spectrum of cancer care, from university hospitals and comprehensive cancer centers to oncologists in private practice. And since the start of the program in 2013, the levels of patient characterization have increased and currently include information on the exome or genome. This depends a little bit on the partner side within the network, the transcriptome and methylome of each tumor, as well as cancer-relevant germline alterations. And using a standardized workflow for recruitment and consenting of patients, sample processing, molecular profiling, and bioinformatic analysis, we have now analyzed approximately 3,200 patients. So the number on this slide is slightly outdated at the time of the last interim evaluation in mid-September. And these patients represent a fairly broad spectrum of entities, represented by the pie chart, of which approximately 75% are rare cancers. And using 468 single gene and 6 composite or compound biomarkers, we are able to make treatment recommendations in approximately 75% of cases, and we assign them to 7 different so-called intervention baskets based on the cellular processes or pathways that are disrupted by the respective molecular alterations. And if you look more closely at this distribution, you will see that soft tissue sarcomas account for the largest proportion of our cohort, reflecting a significant unmet medical need in these patients who are often younger patients and have only few treatment lines available. And the following slides show specific examples of how the results of molecular profiling can influence the clinical management of individual soft tissue sarcoma patients. First, genome and RNA sequencing result in a re-evaluation of the clinical diagnosis in approximately 5 to 10% of soft tissue sarcoma patients. And this re-evaluation is always done in close consultation with colleagues from pathology, and it may sometimes have immediate therapeutic consequences. And in addition, we observed that some undifferentiated carcinomas can be classified as sarcomas based on the genetic data. So we would conclude from our own experience within the master program that broad molecular analysis has relevant diagnostic value in the field of soft tissue sarcomas. And secondly, the systematic analysis of germline alterations, which we always look at because we need a matched normal control, revealed that approximately 10% of our patients have likely or clearly pathogenic variants in known tumor predisposition genes, and approximately 5% of our patients are carriers for autosomal recessive disorders. And it's also important to mention that in 75% of the cases where we identify a pathogenic germline variant, this was not known to the patient or their family before the molecular analysis was performed. And in addition, germline analyses also provide entry points for molecularly targeted therapies, for example, PARP inhibitors in patients with inactivating BRCA1 or BRCA2 or PALB2 mutations. So we would argue that germline analysis should be an important element in modern precision oncology approaches. And third, and perhaps most importantly, comprehensive molecular tumor profiles often provide starting points for individualized soft tissue sarcoma treatment. And I'll try to illustrate that using a number of specific examples. So this is the case of a young woman in her 40s with metastatic pulmonary epithelioid hemangioendothelioma and no response to 2 lines of systemic therapy. This is an ultra-rare sarcoma for which no standard treatment exists. And her tumor was found by whole exome sequencing. This is the peak labeled with an arrow, to harbor a focal amplification on the long arm of chromosome 4 that affected, among other genes, the PDGF receptor alpha gene and was associated with very high expression of PDGF receptor alpha, as well as its cognate ligand as assessed by RNA analysis. And these findings provided a molecular rationale for treatment with a multi-tyrosine kinase inhibitor with pazopanib, which resulted in a partial remission in this specific case that lasted for more than 6 months. And while this patient is an interesting individual case, an important question is, of course, whether new starting points for molecular stratification and targeted therapy of larger patient groups can also be found. And that this might be the case is illustrated by the example of another young patient with, in this case, refractory retroperitoneal leiomyosarcoma and amplification of the FGFR1 gene, who benefited from pharmacologic FGFR blockade in the context of 2 subsequent clinical trials for more than 1 year. This is another individual case, but based on this individual clinical observation, we have determined through analysis of 3 different retrospective patient cohorts from Heidelberg, Munich, and the TCGA dataset that alterations of FGFR1 occur in at least 7 different soft tissue sarcoma subtypes, and that the sensitivity of soft tissue sarcoma cell lines to pharmacologic FGFR inhibition is primarily dictated by aberrant FGFR1 expression and sufficient inhibition of the RAF/MEK/ERK pathway. So here we have, we think that we have identified a recurrent event, a low-frequency recurrent event that provides a valid therapeutic target in different soft tissue sarcoma subtypes. And another fairly recent example is the discovery of an activating mutation in the ERB2 receptor tyrosine kinase in a patient with a rare tumor of the peripheral nervous system, so-called neurofibroma schwannoma hybrid nerve sheath tumors, who has been responding to small molecule ERB2 inhibition with lapatinib for more than 5 years. And based on this observation, we have now analyzed 18 additional cases that we could identify through our network of the German Cancer Consortium. And we found that ERB2 mutations are in fact recurrent events that occur specifically in hybrid nerve sheath tumors that are associated with sporadic schwannomatosis. And we also observed that these tumors are part of a distinct subgroup of peripheral nerve sheath tumors that are defined by DNA methylation profiling. So we think that these mutations are on one hand provide a valid therapeutic target, but might also have diagnostic or differential diagnostic value. And the assumption that other pathways besides receptor tyrosine kinase signaling may also have importance as therapeutic targets in patients with soft tissue sarcoma is supported by this case of a woman in her 50s with chemo-refractory metastatic uterine leiomyosarcoma. And since we identified a biallelic TSC1 loss in this tumor, this patient was started on the mTOR inhibitor everolimus, and this resulted in a very good partial response after 3 months. And this result is consistent with our previous observation in the context of a survey of the genomic and transcriptomic landscape of leiomyosarcoma, that alterations potentially associated with constitutive activation of the PI3 kinase AKT-mTOR signaling axis are present in more than half of these tumors. And this observation also illustrates the value of patient cohorts that we are able to assemble in precision oncology programs, such as the master program. And as alluded to earlier, an important aspect is that our comprehensive molecular profiling approach also allows us to capture compound or composite biomarkers that comprise multiple different components. For example, whole exome and whole genome sequencing identifies genomic imprints of defective DNA repair via homologous recombination in nearly all patients with advanced stage leiomyosarcoma and nearly all patients with advanced stage chordoma, suggesting that the concept of BRCAness, which we know from patients with breast cancer, ovarian cancer, pancreatic cancer, or prostate cancer as therapeutic liability, might extend beyond these common epithelial cancers. And the potential clinical value of this discovery is illustrated by a 57-year-old chordoma patient who showed an exceptionally strong BRCA phenotype and who responded to pharmacologic PARP inhibition for a period of 10 months. In this case, also illustrated that sequential genetic analyses before and after targeted treatment can be very informative, because whole genome sequencing of a repeat biopsy that we took from a progressive region of the tumor revealed a newly gained missense mutation in PARP1 itself. So in the enzyme that is inhibited by the PARP inhibitor that was given to this patient, and a mutation that presumably disrupts the autoinhibitory so-called helical domain of the PARP1 enzyme and stabilizes the active conformation. And we think that this validates PARP1 as a therapeutic target in this specific tumor. So the overall implications of our stratification approach are particularly well illustrated by the first 1,310 enrolled patients for whom we have comprehensive and manually curated clinical information available. And these are results that we recently published. So we made evidence-based treatment recommendations in 88% of these patients. And these recommendations were implemented in 32% of cases, of which 55% had an objective response or stabilization of their disease, and this included patients who had received recommendations with a low level of evidence. And in addition, we observed that the molecular data helped to clarify the clinical diagnosis, and I mentioned this before, in nearly 5% of cases. And another aspect that I mentioned before, systematic analysis of germline alterations showed that approximately 15% of patients have pathogenic variants in known tumor predisposition genes or are carriers for an autosomal recessive disease. And why we view these results as encouraging, they also show that there are some entities or groups of entities in which our genome and transcriptome centered approach has not been successful so far. So for example, treatment results in patients with bone sarcomas, osteosarcoma, Ewing sarcoma are rather disappointing, and we need to identify new layers of patient characterization that can help us improve outcome for these patients. And this slide looks at the progression-free survival intervals. So the proportion of patients in whom recommended treatments were associated with a prolongation of the so-called progression-free interval or the progression-free survival ratio, that is the progression-free interval under targeted treatment divided by the progression-free interval during the last systemic treatment before molecular analysis. So the proportion or the prolongation of this progression-free interval by at least 30% compared with the last systemic treatment before molecular analysis was 36%. And this included most soft tissue sarcoma patients except those with leiomyosarcoma. These calculations were based on cases representing a total of 20 different disease categories, and a PFS ratio greater than 1.3 in more than 30% of patients was found in 16 of these subcohorts, and a PFS ratio greater than 1.5 in more than 30% of patients was detected in 12 of these subcohorts. And the ultimate clinical goal of MASTER is to move away from assessing the therapeutic activity of targeted interventions on an individual case basis. And towards this goal, we are currently working on a continuously growing portfolio of cross-institutional basket trials that are linked to the MASTER diagnostic platform and that assume that the presence of a specific molecular marker predicts response to a targeted therapy independent of tumor histology. And a specific example is shown here. This is a randomized phase 2 trial in which we are evaluating the efficacy of combination treatment with olaparib, a PARP inhibitor, first generation PARP inhibitor, and trabectedin, a conventional cytotoxic drug that induces DNA double-strand breaks in patients with genetic features of impaired DNA repair via homologous recombination. So in patients with the BRCA phenotype that I talked about earlier. And to date, we have randomized 72 patients that represent more than 10 entities, including a number of soft tissue sarcoma cases and also 5 chordoma cases. And the first interim analysis has demonstrated non-inferiority of the investigational treatment and found that a substantial proportion of the crossover population benefits from the experimental treatment with olaparib and trabectedin. This chart just provides an overview of other molecularly stratified trials that we have linked to specific intervention baskets of our diagnostic platform. So our hope or our ultimate goal is to link at least one trial to each of these intervention baskets. And one initiative that we have activated earlier this week, and that is of course also open to patients with soft tissue sarcoma, is shown here. This is CRAFT. CRAFT is a phase 2 trial that includes 6 molecularly defined treatment arms, and this protocol's unique feature is that we will be investigating combinations of targeted agents and a PD-L1 antagonist, atezolizumab, in most treatment arms to counteract intrinsic or acquired treatment resistance. And as I mentioned, this treatment trial was just initiated this Tuesday, and we have enrolled the first patients. Yeah, and finally, I would like to briefly discuss a scientific project. I would like to outline a project in which we aim to identify predictors of response to pazopanib. Pazopanib is, as I mentioned before, a multityrosine kinase inhibitor, and this is a drug that is approved for the treatment of patients with advanced soft tissue sarcoma. But the problem is that we really don't know who are these patients that will benefit from this treatment. So data from a phase 3 trial conducted by the EU-RTC have shown that approximately 10% of patients benefit from pazopanib over time. However, molecular targets, the relevant molecular targets of this drug and factors that predict response to pazopanib are largely unknown. And our goal is to use our resources and our master network to comprehensively characterize precisely these patients on the molecular level. And this is, of course, challenging because we estimate that there are 10 to 15 patients per year in Germany who will benefit from pazopanib in the longer term. So the main challenge is to identify these patients. And to this end, we have established a collaboration between all sites of the German Cancer Consortium and their respective catchment areas. So I showed you the map of Germany earlier, and the German interdisciplinary sarcoma group and a patient organization, the German Sarcoma Foundation. And the purpose of this collaborative effort is to create a patient-partnered research project, which will hopefully allow us to perform an in-depth analysis of a cohort of exceptional pazopanib responders and thereby optimize the use of this drug in the clinic. And finally, I wanted to show you one more aspect that is related to our daily life in precision oncology at the NCT in Heidelberg. So this slide illustrates that integrating the different information levels and the nomination of individualized or personalized treatments require interdisciplinary molecular tumor boards. And at the NCT in Heidelberg, 3 molecular tumor boards are held per week. On Wednesdays and Fridays, comprehensive molecular profiling results have been discussed now for several years as part of the specialized programs that I mentioned earlier, specialized programs such as the master program of the German Cancer Consortium. And last year, we also established a 3rd molecular tumor board to specifically discuss panel sequencing results in patients with solid tumors. And we have closely collaborated with the Institute of Pathology Heidelberg and also our partner site, the National Center for Tumor Diseases in Dresden in this context. And this brings me to my summary. So in summary, our experience shows that comprehensive molecular profiling of soft tissue sarcoma patients, but also many other solid tumors, as you've seen before, in a multi-center clinical setting is feasible. our experience is that such diagnostics complements and advances routine molecular diagnostics. And it certainly creates therapeutic opportunities. And we, in our view, comprehensive molecular profiling is particularly useful for detecting rare, complex, and also newly emerging cancer drivers, because we do not have to adapt specific panels. But if we use whole genome sequencing, we get an integrated view of all genes in one go. It's very clear that our approach needs to be evaluated within controlled clinical trials of genomics-guided therapies, and we think that we are making good progress in that arena. And our approach is also being integrated with additional layers of patient characterization. So right now we are looking at proteomic approaches, we are exploring epigenomic approaches, we are very interested in immune profiling, functional profiling such as ex vivo drug sensitivity profiling, and we're trying to integrate multi-parameter imaging into the master program, but right now these are exploratory work packages that we are not yet using in routine patient care. And lastly, our approach will also be extended beyond medical oncology, so beyond drug treatment to additional treatment modalities. So we are very interested in stratifying patients undergoing radiotherapy according to their molecular profiles. And we think that in the foreseeable future, molecular stratification will also have value in personalizing surgical interventions. And with this slide, I would like to acknowledge everybody who helped establish this network within the German Cancer Consortium. So these are the members of our DKTK Master Scientific Board, and they are representing many more individuals at multiple sites who have contributed to the success of this project. And with my very last slide, I would like to thank you again for inviting me to contribute to this interesting symposium, and I'm looking forward to the Q&A session. Thank you again.